On almost every postnatal ward in the country, there's a tube of dextrose gel within arm's reach. The baby of a mother with diabetes, the small for dates baby, the late preterm, we know they're at risk of their blood sugar dropping in the first hours of life, and a squirt of gel into the cheek feels like cheap insurance. So here's the question a large trial has now answered. If you give that gel to prevent a low sugar rather than to treat one, does the baby do better years down the line? The answer, it turns out, is no, and there may be a small cost attached. That's the hPOD follow-up, and it's our first main story today. So, this week, we're going deep on prophylactic dextrose gel and what it does or doesn't do by school age, looking at new UK data on whether every child with Staph aureus in the blood really needs an echo, and in What's Caught My Eye, we've got decision rules that cut x-rays in children's limb injuries, a pre-hospital sedation pathway for people with learning disabilities, and a sobering look at how accurately we actually find the right spot for a chest drain. I'm Ian Lewins, and welcome to Two Paeds in a Pod. Welcome to Two Paeds in a Pod, the paediatric medical education podcast about thinking clearly when it comes to child health. Each week, we take a paper, a clinical dilemma, or a tricky topic and work through what it actually means for your practice. So, whether you're in emergency care, general paediatrics, or you see children as part of a wider healthcare role, this is a place to step back, challenge assumptions, and sharpen your thinking. Welcome to the show. Transitional neonatal hypoglycaemia sits right at that join between the labour ward, the postnatal ward and the neonatal unit. Somewhere between 1 in 6 and 1 in 4 babies with a risk factor, such as maternal diabetes, prematurity, being small or large for dates, will have a low blood glucose in the first day or two of life. We screen for it, we feed, and when the sugar is low, we treat. Over the last decade, buccal dextrose gel has become part of that treatment story. The Sugar Babies trial and the work that followed showed that gel rubbed into the cheek alongside a feed reduces admissions to the neonatal unit for hypoglycaemia and reduces separation of mother and baby. That's treatment, a low sugar, then gel. Prophylaxis is a different proposition. The idea there is to give the gel to every at-risk baby before the sugar is dropped to stop it dropping at all. It's an attractive idea, it's cheap, it's simple, and it keeps babies with their mothers. The original hPOD trial, that's hypoglycemia prevention with oral dextrose, did show that a dose of gel at birth modestly reduced the number of babies who became hypoglycemic. But the question that always mattered more was the one about the brain. Does preventing those early low sugars actually protect neurodevelopment? Because if it doesn't, the whole rationale gets a lot thinner. This paper is the school-age follow-up of that trial in JAMA Pediatrics. hPOD was a proper, double-blind, placebo-controlled randomised trial run across 9 hospitals in New Zealand. At-risk babies born at 35 weeks or more, weighing at least 2.2 kilos, got either a single dose of 40% dextrose gel at 1 hour of age or an identical-looking placebo. This follow-up assessed just over 1,000 of those children at 6 to 7 years of age, mostly in their own schools. The primary outcome was neurocognitive impairment, scoring more than 1 standard deviation below the mean on at least 1 of 7 cognitive tests. And there was no difference. 59% in the gel group, 57% in the placebo group, an adjusted difference of 3% that crossed zero and wasn't significant. Now, that headline rate sounds alarmingly high, so it's worth understanding why. When your definition of impairment is failing any one of 7 tests, a lot of entirely normal children trip that threshold. Read it as a comparison between 2 arms, not as a claim that 6 in 10 of these children are impaired. The 2 arms were the same. Where the trial did find a difference, it wasn't in the direction anyone hoped. On the exploratory outcomes, children who'd had the dextrose gel were somewhat more likely to have emotional and behavioural difficulties, 24% against 18, and more likely to score low on psychosocial function, 17% against 12. These are secondary, exploratory findings, and with multiple outcomes tested, you treat a lone signal like this with caution, but it's there, and it's not nothing. So here's the bottom line, and it needs saying precisely, because it's easy to take the wrong message. This trial does not support giving dextrose gel prophylactically, routinely, to every at-risk baby to prevent hypoglycaemia. The cognitive payoff that would justify it isn't there, and there's a hint of harm on the behavioural side. The authors say plainly that the current evidence doesn't support routine prophylactic gel, and that's the honest reading. What this trial does not touch is treatment. If a baby has a documented low glucose, buccal dextrose gel alongside a feed remains a reasonable, evidence-based way to bring it up and keep mother and baby together. Prophylaxis and treatment are 2 different questions, and this paper only answers one of them. My read of the current BAPM framework on neonatal hypoglycaemia is that it already positions gel as part of treatment rather than blanket prophylaxis, but check the live wording before you quote me on that, because guidance moves. The takeaway for the postnatal ward is simple. Keep treating the low sugars. Don't reach for the gel as routine insurance for a baby whose sugars are still normal. This study is in the June edition of JAMA Pediatrics and is by Harding et al. And, as always, the DOI is in the show notes. Our second story stays with the sick child but moves to an older one, and to a question about how hard we should look for a complication we're all taught to fear. Staphylococcus aureus in the bloodstream, Staph aureus bacteraemia, is a serious event at any age. In adults, the reflex is well drilled. Staph in the blood means you go looking for infective endocarditis, and echocardiography is close to mandatory. This UK study asks whether that adult reflex should really be applied wholesale to children in whom endocarditis is genuinely rare unless there's something else going on. This is a retrospective cohort study from 6 hospitals across northwest London covering just over 100 children with Staph aureus bacteraemia between 2018 and 2023. It's by Gray et al. And is in the BMJ Pediatrics Open from June of 2026. In this study, 70% of children had transthoracic echo, 30% did not. Endocarditis was confirmed in 4 children, about 5.5% of those who were scanned. And here's the part that matters. Every single one of those 4 had an established risk factor. 2 had congenital heart disease, 2 had central venous catheters, 1 had a history of intravenous drug use. All 4 had right-sided heart disease. Not one case of endocarditis turned up in a child with a structurally normal heart and no risk factor. The features that tracked with endocarditis were the ones you'd hope for: embolic phenomena, bacteraemia that persisted beyond 72 hours, and polymicrobial growth on the culture. The echo group also stayed in hospital far longer, a median of 17 days against 4, though you'd have to be careful there because the sicker children were always more likely to be echoed in the first place. That's confounding by indication, not proof that the echo caused the longer stay. So what? The argument the authors make, and it's a reasonable one, is for risk stratification rather than universal scan. If a child has a structurally normal heart, no risk factors for endocarditis, and nothing clinically suggestive, so no embolic signs, no murmur, no persistent or polymicrobial bacteraemia, then a routine echo may be adding cost, time, and a hospital stay without changing anything. Reserve the scan for the child with a heart lesion, an indwelling line, a history that raises the risk, or clinical or microbiological features pointing towards endocarditis. The honest caveats are real. This is retrospective, it's a single region, and 100 children is not a large number when your outcome of interest occurs 4 times. It needs prospective validation before anyone rewrites a protocol. But as a prompt to pause before you reflexively order an echo on every child with staph in the blood, it's a useful piece of UK data, and it fits a theme this podcast keeps returning to, which is that more investigation is not automatically better care. As always, DOI in the show notes. Now, let's move on to the 3 things that have caught my eye this fortnight. First item. Do decision rules safely cut x-rays from children's limb injuries? This is a paper by Kirkland et al. And is in the EMJ, the Emergency Medicine Journal. This is a systematic review and meta-analysis of 8 studies and nearly 8,000 children, asking whether clinical decision rules and guidelines reduce unnecessary x-rays for arm and leg injuries in the emergency department. The headline finding was that decision rules for ankle injuries cut radiography substantially, with an odds ratio of around 0.11. A wrist rule also reduced imaging, but missed 8 fractures. And in one trial where triage nurses applied a rule, imaging went up and 16 injuries were missed. Why does this study matter? Well, it's a clean reminder that the value of a decision rule depends on which rule, which joint, and most crucially, who's applying it. Reducing imaging is a good goal, but not if you trade it for missed injuries. The caveat on this study was that most of the included studies were before and after designs, so the certainty of evidence is moderate at best. Next up, our second item is pre-hospital oral sedation for people with learning disabilities, and this is from Monroe et al. From the Emergency Medicine Journal. What is this? This is a first-year evaluation of a pathway from the Barts Health Physician Response Unit in North East London, offering carer-administered oral ketamine and midazolam, given in a drink under the response unit team's supervision, to let people with learning disabilities tolerate investigations or procedures that would otherwise be impossible. The headline finding from this study was that of 36 people referred, 9 were sedated, there were no serious adverse events, just 2 minor ones, and every patient tolerated a procedure that had previously been out of reach. So why does this matter? Well, as a model of reasonable adjustments done properly, meeting the patient where they are rather than forcing them into our default or restraint or a needle, it's well worth knowing about. The caveat on this one is that this was small numbers and was a service evaluation rather than a true trial. And finally, our third item is how accurately do we find the spot for a chest drain? And this comes from Biella et al. From Paediatric Emergency Care. This is a study of 15 paediatric emergency physicians marking the correct site for a chest drain, the 5th intercostal space, using landmarks alone, and then ultrasound was used to check them. The headline finding was that across 240 marks, only 37% were actually at the 5th space. Nearly 1 in 10 sat below the diaphragm, and the more experienced clinicians were more likely to mark too low, not less. This matters because a chest drain is a rare, high-stakes procedure where getting the site wrong causes real harm, and this makes a strong case for a quick ultrasound look before you cut. The caveat on this study was that it was a single centre with only 15 clinicians, and they were marking skin rather than placing actual drains. So, the 3 things I'd take away this fortnight. Number 1. Prophylactic dextrose gel for at-risk newborns doesn't improve cognition by school age and may carry a small behavioural cost. So keep treating low sugars, but don't give gel as a routine insurance for a baby whose glucose is still normal. Number 2. Not every child with Staph aureus in the blood needs an echo. If the heart is structurally normal and there's no risk factor or clinical clue, risk stratify rather than scan reflexively. And 3rd, if you place chest drains, the landmark you trust may be lower than you think, and experience doesn't protect you. A quick ultrasound check is worth the 30 seconds. All references and DOIs are in the show notes. If this episode was useful, please share it with a colleague, and I'll see you in a fortnight. Thanks for spending your time with us on 2 Paeds and a Pod. If this episode sharpened your thinking, make sure you're following or subscribed wherever you listen. Share it with your team, use it in your next teaching session, and let's keep the conversation going. If you value this kind of learning, please leave a rating or review. It genuinely helps more clinicians find the show. We'll see you next time.